I'm going to talk about the anatomy of the chest wall and then the anatomy of the respiratory tract, and then I'm going to dive into upper respiratory emergencies and then actual pulmonary emergencies. So to start off, the respiratory tract actually starts with the nasal cavity and the nasopharynx. It also includes the oropharynx, the laryngopharynx, and the vocal cords. So structures that we typically look at when we're doing respiratory exams in the upper airway are going to be like the nasal concha and the sinuses. In the oropharynx, we're looking at the palatine tonsils to see if they're red or swollen. We're also looking at the uvula to see if it's midline, red or swollen. And the soft palate, and then also the epiglottis. One thing too is that the vocal cords have a vestibular fold and a vocal fold. So the vestibular fold is right here, and then the actual vocal cords are right here. The vestibular fold is also known as the false vocal cords. The space between the vocal cords is known as the glottis, and then once you pass below that space into pass below the glottis, you're in the trachea, which is part of the lower respiratory tract. And then to dive into the chest wall anatomy. So ribs 1 through 10, when we're breathing in and out, they have a pump handle motion. So they kind of go up and down like this. And then, oh, I'm sorry, that is not correct. Ribs 1 through 5 have a pump handle motion. Ribs 6 through 10 have a bucket handle motion, so they kind of go up and down like this. And then 11 and 12 have a caliper motion, and they move like this when we're breathing. Ribs 1 through 10 are connected to the sternum by the costocartilages, and then 11 and 12 are just floating ribs. They're not connected anteriorly at all. So the major muscle of respiration is going to be the diaphragm, and the diaphragm connects anteriorly to the xiphoid process and the costal margin, and then it all connects to the 11th and 12th ribs laterally, and posteriorly it connects to the lumbar spine. The other muscles of respiration that we have are our minor muscles of respiration, and those are external and internal intercostal muscles, which are going to be in between the ribs. And then we have our scalenes and our sternocleidomastoids, and as well as our abdominal muscles, and pec minor actually is a minor muscle of respiration as well. And then one thing that I really like about this picture on the left here is that it shows kind of the silhouette of the heart, and that kind of tells us where the heart is in relation to the lungs. And some of the things that I talk about today, knowing that the right atrium butts up against that right middle lobe of the lung is going to be important. And then on the left side, the left ventricle is what is sitting up against the left lung. So diving in a little bit deeper, each lung is contained in a 2-layered sac called the parietal or the pleural sac. This is composed of 2 layers. The visceral layer is the innermost layer, and it's connected to the lung tissue itself. And then the parietal layer is the outer layer, and it lines the thoracic cavity. And that's where it adheres to. The space in between the visceral and parietal pleura is known as the pleural cavity, and it is filled with pleural fluid, which helps decrease the friction when we're taking a breath in and a breath out, and it just makes it easier for our lungs to move around in there. There's a space in the inferior portion, or in between the inferior portion of the lung and the parietal pleura, known as the costodiaphragmatic recess. And if you ever have any fluid that starts to accumulate in your lungs, it's going to start accumulating here before it fills up the rest of the cavity. And then in the middle there, we have the mediastinum, and the mediastinum contains some really important structures like the aortic arch, the pulmonary artery and veins, parts of the carotid artery, and then parts of our trachea and esophagus as well. And so to look at the anatomy of the lungs themselves, each of our lungs is divided into lobes. The left lung has 2 lobes. It has an upper and a lower lobe, which is divided by the oblique fissure. The oblique fissure starts around the 4th or 5th thoracic vertebrae in the back, and then it follows the 6th rib anteriorly when it comes down. And then the right lung has 3 lobes. It has an upper, middle, and a lower lobe. And then with the right lung, again, the oblique fissure separates the upper and lower lobes, and it starts at the 4th and 5th thoracic vertebrae following that 6th rib. But with the right lung, when you get to about the mid-axillary line is when you get the horizontal fissure that branches off of that oblique fissure. And that separates the upper lobe from the middle lobe. And the horizontal fissure follows the fourth rib anteriorly. So it's a little bit higher up than the oblique fissure. And you can see kind of how big of a difference that makes in the patient on this picture. It shows that in the posterior lung fields, your lower lobes are going to make up the majority of your posterior lung fields. And then the yellow is just that little bit of your upper lobe. And then anteriorly, you have very little of your lower lobe, and the majority of it's going to be your upper lobe on the left, and then the right is going to be, again, the majority is the upper lobe, but you also have your middle lobe anteriorly and laterally on the right lung, but no evidence really of the middle lobe on the posterior aspect, maybe just like a tiny bit right there. And that can get really important, you know, for any type of emergency where you're looking at to see where in the lung something is, particularly like a consolidation, fluid, or a foreign body that's going to kind of dictate your treatment for the patient. And then if you remove the lung tissue, this is kind of what you get. So you have your trachea, which comes down and bifurcates or splits into the right and left main bronchus. And that bifurcation takes place at around T4, or anteriorly, it takes place around your sternal notch, which is also the level of your second rib on your chest wall. And then each primary bronchus splits into secondary bronchi. So on the right lung, you're going to have an upper, middle, and lower secondary bronchi. On the left lung, you're just going to have an upper and a lower secondary bronchi. And then each of those secondary bronchi again divide into tertiary bronchi, and finally into our respiratory bronchioles. So everything from the tertiary bronchi to the trachea is the conducting portion of the respiratory system. So this means that it's solely responsible for just moving in air in and out. It doesn't participate in gas exchange at all. We don't start to get gas exchange until we get to the respiratory bronchioles, because that's where we first start to see the alveoli. And alveoli are going to be little air-filled sacs that are at the end of the respiratory bronchioles, and the respiratory bronchioles have some scattered alveoli on them as well. And each of the alveoli are going to be surrounded by a capillary bed. And so when we take a deep breath in, oxygen comes in and it diffuses across the alveolar sac into the capillaries, and CO2 comes in from the blood to the alveolus and out when we take a breath out. And then, oh, I missed something, sorry guys. So the alveoli, on top of participating in gas exchange, also produce surfactant. And surfactant is a really important protein for our lungs because it equalizes the pressure between the small and the large alveoli. So if we didn't have surfactant, the pressure in the smaller alveolar sacs would be much greater than the pressure in the larger sacs, and air would flow down its pressure gradient into the larger alveolar sacs, and that would cause a collapse of the small alveoli. And then we're, you know, if we collapse some of our small alveoli, we're losing out on areas of our lungs that can participate in gas exchange. Surfactant also decreases the surface tension, and it allows for greater compliance of our lung tissue. So it kind of decreases the amount of work that we have to do to breathe. So for the physiology of breathing, inspiration when we take a breath in is actually an active process. It requires the contraction of the diaphragm and the external intercostal muscles. And when we take a breath in, when those contract, it increases the volume of our thoracic cavity. And when we increase the volume of the thoracic cavity, it actually decreases the pressure in the thoracic cavity. And when you do that, it increases the volume of the alveoli, which decreases the pressure within the alveoli and allows air to flow down its pressure gradient into our lungs. And then expiration is a totally passive process. So no muscles are contracting when you're breathing out. It's just the relaxation of the diaphragm and the external intercostal muscles. And then it's kind of the reverse process. You increase the pressure in the thoracic cavity, and that forces air out of the lungs. And then forced expiration, on the other hand, though, is an active process. And that's where you're seeing people that are in respiratory distress, they're using their accessory breathing muscles, like their sternocleidomastoids, their abdominal muscles, and things like that. And when people are really working to breathe, you can see the accessory muscle use, and we call those retractions. So I don't know about you guys, but I don't typically think about breathing. I'm not usually aware of when I'm taking a breath in and a breath out. So how does our body know that we need to take a breath? Well, the control of breathing is done by the brainstem, which contains the pons, medulla, and the midbrain. The medulla contains a group of neurons called the dorsal respiratory group, which is responsible for just our everyday standing around rhythmic breathing that we're not really aware of. And then it also contains a group of neurons called the ventral respiratory group, and those are only activated when we need to increase our rate of breathing beyond what's normal. So these areas of the brainstem receive information from receptors in our body that respond to changes in our pH, and those are called chemoreceptors. So our central chemoreceptors are actually located on the surface of the medulla, and those respond to CO2 changes because CO2 can readily cross the blood-brain barrier. And so those receptors are very sensitive to changes in our CO2 levels. And then we have chemoreceptors on our aortic arch and also in our carotid sinuses that detect changes in our oxygen levels. And so whenever those change, those send signals to the brainstem saying, hey, we need to breathe more, we need to slow our breathing down. So if you have an increase in CO2, your pH is going to go down. These receptors are going to pick up on it, send a signal to your brain saying, whoa, we need to breathe faster and get rid of this CO2 and get more oxygen in. And then that's going to send a signal through the phrenic nerve to your diaphragm to breathe. And now we're going to get into some respiratory emergencies. So we'll start off with the upper respiratory emergencies. So the first one is, I know you guys all know that kids love to stick stuff in their mouths, and sometimes that ends up with them swallowing it or it getting lodged. One thing that is really dangerous for kids to stick in their mouths and accidentally swallow is button batteries. And that actually happens quite commonly. But batteries are super corrosive, especially the small hearing aid type batteries. And what they can do is they can cause what is called a tracheoesophageal fistula. And so essentially the button battery will get stuck and it will erode through the soft tissue of the esophagus. It'll erode through the soft tissue of the trachea. And then what you end up with is a hole that connects your esophagus to your trachea, which I think you guys can imagine is bad because anytime you swallow spit, liquids, food, that leaves an opportunity for that material to get into your lungs and aspirate. And then you get a pneumonia or an obstruction, and it can really mess with your breathing. The other thing that can happen with these button batteries is that you can get vocal cord paralysis, which is something I did not know could happen, and burns of the esophagus and trachea as well. Patients that have this are going to typically present with shortness of breath, dyspnea, and dysphagia. They'll have difficulty swallowing, and sometimes vomiting too. And to treat it, you're going to get an x-ray to see where the battery is in the airway or in the esophagus. And then they do an endoscopy to go in and remove the battery. And then for tracheoesophageal fistulas, they actually can either go in through the chest wall, like make a incision in the chest wall, open you up, and they repair it, or they can go in through the sternal notch, which is just in between your clavicles here. And they can go down in it, and what they'll do is they'll take away any of the necrotic tissue that's been burned by the battery, and then they close up the holes so that they're not connecting the trachea and esophagus anymore. And then next is croup, which again is super common, and especially this type of year, croupy kids are seen all the time. So croup can range from mild to severe in its presentation, and it usually is very mild to moderate and doesn't require emergent intervention, but it can become very severe. So it is typically a viral infection and typically caused by parainfluenza virus, but it can also be caused by respiratory syncytial virus, otherwise known as RSV. And it's very rarely bacterial, but it can be. So when is an emergency? When the child is in respiratory distress, and when they're presenting with respiratory distress, they're going to have shortness of breath, tachypnea, low oxygen saturations, and they're going to have the retraction of their accessory muscles. They're really going to be working to breathe. So before they get to that point though, croup typically presents with your typical upper respiratory infection symptoms. So you're gonna have runny nose, congestion, cough. You're just not gonna be feeling real good, fever. And then it also is distinguished from a normal URI though, in that croup ends up giving you laryngeal and tracheal swelling, which causes narrowing of the larynx and the trachea. And that's where you get the stridorous breathing, which is that really loud, hoarse breathing. And you get that very characteristic seal-like barking cough with the croupy kids. And that shows up, that swelling shows up on x-ray as what's known as the steeple sign, which you can see that the tissues are so swollen that they're narrowing the trachea and causing that airway obstruction. And so when kids are presenting with respiratory distress for this, they're going to get supplemental oxygen, and if they need it, they're going to get intubated and hospitalized just to protect their airway. If it's a mild to moderate case, croup gets treated with racemic epinephrine, which is just aerosolized epinephrine, and then they also get dexamethasone, which is a steroid, and that decreases the inflammation within their airway. And then next is epiglottitis. So we had, if you remember back in our anatomy, we have our epiglottis in our oropharynx area. It's kind of part of the division between the upper and lower respiratory tract. Epiglottitis is a severe inflammation of the epiglottis, and it's usually caused by Haemophilus influenzae, and so it's a viral infection as well. And if you guys know what cellulitis of the skin is, where you get really red, inflamed, infected skin, epiglottitis is essentially cellulitis of the epiglottis, and it can get really, really swollen and edematous and actually lead to full-on airway obstruction. And the typical symptoms for epiglottitis are going to be fever, sore throat, and then its characteristic sign is a cherry red epiglottis on exam, if you can visualize it. And then they're gonna have shortness of breath, often have drooling because they're not managing their secretions very well. Stridor, they'll have that really hoarse breathing again because they have narrowing of their and obstruction of their airway. And then tripoding, which kids will often put. Tripoding is they'll put their arms out and they'll lean forward and extend their neck, and that's the kid trying to open up their airway as much as they possibly can. This is typically usually seen in children as well, like croup is. It's not typically seen in adults. It can lead to airway obstruction in a couple of ways, just because it gets so edematous and swollen, or the epiglottis itself can actually start to curl inferior and posterior, and that will obstruct the trachea. And so for these people, you're going to give them supplemental O2. They try to use bag mask ventilation to see if they can oxygenate well enough with that before intubating. But then if they can't do that, intubation, and then it's treated with ceftriaxone and vancomycin. And then anaphylaxis. Again, this is another pretty common one that's seen often, but it's just an allergic reaction. It can be caused by other things, but it's very typically an allergic reaction to something. It's a multi-system syndrome that's related to the release of histamine. And when it becomes a respiratory emergency is when it causes really severe angioedema. I like this picture that I found because you can kind of see the progression of how swollen this poor individual got, and then you see that he's intubated and not doing so well, but then he gets better. Intubation is indicated if they're in respiratory distress. Some of the symptoms that you can see with angioedema or anaphylaxis are sneezing, runny nose, laryngeal obstruction, shortness of breath, wheezing. It actually can lead to pulmonary edema too, which I didn't know before researching this a little bit, and respiratory arrest. So of course, like with any allergic reaction, you're going to want to remove the inciting cause of the reaction for treatment, and then patients are given epinephrine IM and supplemental oxygen, and then intubation. And then one thing that is kind of, it's not a common occurrence, but can happen with angioedema is if the angioedema is so severe that you can't intubate the patient, they do what is called a cricothyrotomy, which is, did it tie?
Just click it on the side.
Oh. There we go.
Yeah.
Okay, so for a cricothyrotomy, you're going to make an incision in the cricothyroid membrane, which sits in between the thyroid cartilage and the cricoid cartilage. And I have never personally seen one of these. I didn't know a whole lot about it. And so I have a video to show you guys that kind of explains the process and why you do it.
A cricothyroidotomy is an emergency procedure that is performed on patients in respiratory distress, and where you, as the care provider, cannot obtain a definitive airway. That being said, the major indication to perform an emergent cricothyroidotomy is when you cannot obtain a definitive airway by orotracheal or nasotracheal intubation. Some reasons why you wouldn't be able to obtain an airway include a patient with a very difficult anatomy, patient with excessive amount of secretions in the airway, or physical obstruction of the airway by a large mass or object, or massive facial trauma. Take this man, for example, who's peacefully walking down the street. He's brought into your emergency resuscitation bay, and you attempt an intubation. I'm having trouble begging. There's a lot of resistance.
His oxygen saturation is dropping.
You go to take a look, but you're unsuccessful. His oxygen saturation is dropping, and now he's failing to oxygenate. You also notice it's getting more and more difficult to ventilate him with a bag valve mask. Now he's failing to ventilate. You're likely getting nervous. What's next? Should you try again? Or should you let someone else try again? At this point, time is running, and the brain is starving of oxygen. The next best thing to do now is to grab your scalpel and cut. But where do you cut? Here's the larynx and the superior portion of the trachea. There are a lot of structures here. Luckily, there are only a few structures you need to remember. The cricothyroid membrane is your point of interest. This is the membrane you will puncture and pass your endotracheal tube through. It's tightly situated between the thyroid cartilage superiorly and the cricoid cartilage inferiorly. Now pay careful attention how these key structures lie in the midline of your patient. That is the direction you will be cutting in, especially in an emergent situation. That's because there are some important structures that are found immediately lateral to the larynx. So now that you know your landmarks, what are you going to need to save this person's life? It's simple. You only need 4 essential things: your finger, a scalpel, a gum elastic bougie, and a 6O endotracheal tube. If you have time, you can choose to clean, but remember, brain is time, especially if this is an emergent procedure, so cleaning is not really necessary. First, you want to palpate your landmarks. Use your non-dominant hand to palpate the thyroid cartilage. You could also feel for the laryngeal notch to orient yourself to midline. You'll want to next palpate the cricoid cartilage so that you can define the inferior edge of your target incision site. Because remember that the cricothyroid membrane lies between the cricoid and thyroid cartilage. Once you've oriented yourself, you can start feeling midline for the cricothyroid membrane, which will be the target puncture site. When you're ready to cut, hold the lateral edges of the larynx so that when you cut through the skin and soft tissues, it stays midline and does not shift underneath the soft tissues when you make your first incision. After each incision, palpate feeling for the cricothyroid membrane. You may need to cut a little deeper each time, but keep in mind this is not a delicate, gentle incision. Your incisions should be deep enough so that you can palpate the cricothyroid membrane after 1 to 2 incisions. Once you're through the soft tissue, rotate the scalpel 90 degrees and use the scalpel to puncture through the cricothyroid membrane. You're going to make small horizontal incisions across the membrane, enough to fit your finger between the thyroid and cricoid cartilage and into the airway. This is where it can get messy. Blood may begin to pool into your visual field, and you will likely lose sight of your incision. Don't panic. Remember, this is going to be primarily a procedure by palpation, so there's no need to blot the field with gauze or suction. In fact, you could use the blood as lubricant to slide your fingers over the landmarks to reorient yourself, and then sliding your index finger past the flanking cartilages. With your finger in place, exchange it with your bougie, aiming it downward into the trachea. Once you've made this exchange, you can now feed the endotracheal tube over the bougie and into the airway. For more information and learning material on
Caitlin, I have a question real quick.
Yeah.
You mentioned pulmonary edema with anaphylaxis. So how soon would that present? Did you see that in the readings?
I did not.
I was curious, because like, yeah, you have wheezing, but then when you get crackles too, and like a little low or something.
Yeah, I didn't come across that in my readings. That's a really good question.
Yeah, 'cause I mean, I didn't think about that. That makes sense. But
I would assume it's not acute. I would assume that you're probably like at least a few hours in before you start to get fluid accumulation in your lungs.
that
But
makes sense.
yeah, that's a great question. I was even surprised to know that it caused pulmonary edema. I didn't know anaphylaxis could do that. So that is a cricothyrotomy, kind of terrifying, but sometimes it's needed. And then now we're gonna go ahead and go into the pulmonary emergencies. So first up is a pneumothorax, and then you can have a regular pneumothorax and then a hemopneumothorax. And the difference really is just that a hemopneumothorax is where there's blood in the pleural space instead of just air. But a pneumothorax is air in the pleural space, and it collapses the lung tissue. You can have a primary spontaneous pneumothorax, which means that you don't have any prior lung disease or underlying lung issues, and you just have a spontaneous pneumo. Or you can have a secondary spontaneous pneumothorax, which you do have underlying lung disease like COPD or cystic fibrosis, and that kind of precipitates the pneumothorax happening. They can also be associated with structural abnormalities like patients with Marfan syndrome or Ehlers-Danlos syndrome, which are connective tissue abnormalities. And of course, trauma related. One thing that I didn't know before doing the research on these as well is that they can be what's called catamenial pneumothoraces, which are related to menstrual cycles in women. So you can get thoracic endometriosis and get a pneumothorax from your menstrual cycle. Chemopneumothoraxes are caused by trauma most of the time. I don't think there's really anything else that causes them. With really small pneumothoraxes, or pneumothoraces, they will just observe and see if the lung reinflates on its own. If you have a significant pneumothorax like this individual here, they get either needle aspiration or a chest tube. A needle aspiration, you're going to stick a needle with a catheter in the second intercostal space along the mid-clavicular line. And then they recommend taking about 2.5 to 4 liters of air off with that method, and not going above that. But if you place a chest tube, you're going to go in at the 5th intercostal space at the mid-axillary line. And for that, those are usually attached to water seals and they let them drain to gravity. So they have the water seal at the floor of the bed, and they let it just drain to gravity. And if it doesn't re-inflate within 24 to 48 hours, they actually remove the water seal and place it on suction. And they start to like suck the air out to try to get that lung to re-inflate. And as you can see, this guy's having a bad day. There's no lung there anymore. Signs and symptoms, you're gonna have dyspnea, pleuritic chest pain, which is just chest pain when you're taking a deep breath in. And they'll have decreased chest wall movement on the affected side. And then diminished breath sounds. I mean, as you can imagine, you're probably not hearing a lot over there. And then even scarier is a tension pneumothorax. And then this is kind of when I was talking about how that relationship between the right heart and the lung becomes really important. So in a tension pneumothorax, the tension is so great in the chest that it actually causes compression of the vessels and of the heart, and it causes a shift of your structures, which you can see here. So this person's trachea and heart are shifted all the way over to the other side of the chest where they should not be. And tension pneumothoraxes are always caused by penetrating trauma. And they can become really serious because when that compression starts to compress on the heart, we also have on the right side, you have your inferior vena cava, which is your major blood vessel that drains into your right atrium and brings blood back to the heart from the rest of the body. And then you have your right atrium too, which collects that blood. So when you get compression of your inferior vena cava and your right atrium, you're decreasing the amount of venous return to the heart and decreasing the amount of blood that the heart can pump out then to the rest of the body. And so we just had a lecture on this actually recently, and our professor said, like word for word said, Never, ever get a chest x-ray on a tension pneumothorax. If you think somebody has a tension pneumo, you just put a chest tube in. She was saying that they'll be sitting there talking to you, saying they have chest pain and shortness of breath, and then a minute or two later, they're in cardiac arrest because they have compression of their IVC and right atrium. And then next is pulmonary embolisms. So pulmonary embolisms are pulmonary artery obstruction.
That one hit him for 8 as well.
They can be from an occlusive thrombus, from like a blood clot, or they can also be caused by a tumor occluding the artery, atherosclerosis occluding the artery. They can be classified as stable or unstable. The unstable pulmonary embolisms are the ones that are the emergency. So they become an emergency because they increase the pulmonary vascular resistance. And when you increase the resistance in your pulmonary vasculature, you're increasing or you're decreasing the amount of blood that can be coming out of the right ventricle. So you're decreasing the outflow from the right ventricle. And then you also get right ventricular dilation, which leads to right-sided heart failure. And then that right-sided heart failure leads to overall decreased cardiac output and hypotension, which is the sign of an unstable pulmonary embolism. It can also lead to obstructive shock, which again, you get the right ventricular heart failure and you get massive or the hemodynamic unstable PE occurs within the first 2 hours of onset with an obstructive shock. The common causes of a pulmonary embolism are from what is known as Virchow's triad. And so these are going to be your endothelial injury. So the lining of the blood vessel gets injured by trauma or atherosclerosis or something like that. And then that can cause an occlusion. Venous stasis. So if you're traveling for a long period of time and your blood is pooling, that can cause PE. So again, most PEs are actually caused from DVTs. So if you're sitting for long periods of time, your blood is pooling in your legs, it's not moving around, not going anywhere, you get a deep venous thrombosis in your leg, and then that clot will break off and go to your lung. And that's where most PEs originate from. And then you can also get PEs in hypercoagulable states. So things like factor V Leiden and a prothrombin gene mutation where the blood doesn't clot normally. And so you get increased clotting and that can cause pulmonary embolisms. Other risk factors for PE include pregnancy, hormone therapy, tumors, atherosclerosis, heart failure, and IV drug use. You cannot see pulmonary embolisms on chest x-rays. They don't show up unless you get like necrosis of your lung tissue, which isn't as common. So we use what's called a CT angiogram to look at the blood vessels of the lungs, and that'll show a PE. Stable PEs are treated with anticoagulation such as warfarin. It just kind of thins your blood and helps keep it from clotting up. And then unstable PEs are treated with thrombolysis. So TPA, it's a clot buster. So that medication will go in and break up the clot itself. And then if it's bad enough, it can require an embolectomy, which is a surgery to actually go in and physically remove the clot from the lung tissue. Symptoms of a PE are going to be shortness of breath, chest pain, cough, and then sometimes they can have hemoptysis or they can start coughing up blood. And then pulmonary hemorrhage. So pulmonary hemorrhage is just hemoptysis or coughing up blood, anything that can cause that. The bronchial arteries are under high systemic pressure. So the emergencies of hemoptysis are going to come from anything that's causing a bleed in the bronchial arteries. Otherwise, hemoptysis can also just be very mild presentation. So the common causes of life-threatening pulmonary hemorrhages are bronchiectasis. The rapid bleeding occurs to the rupture of the bronchial arteries or the submucosal capillary plexus. Tuberculosis can actually cause ulceration of the bronchial arteries, which again can lead to rapid, massive bleeding. And it can also cause what is known as a Rasmussen aneurysm, which is a pseudoaneurysm in the pulmonary artery. And if that ruptures, that can cause massive pulmonary hemorrhage as well and a lot of hemoptysis. And then you can have a fungus called Aspergillus hyphae that creates cavitary lesions. And another thing that can cause it too is bronchogenic carcinoma. So these things can cause just massive amounts of pulmonary bleeding. The pulmonary bleeding itself too can lead to airway obstruction. And of course, if you have blood pooling in your lungs, that's going to interfere with your gas exchange. So you're not going to be getting enough oxygen perfusion to your tissues. And that eventually leads to hemodynamic instability. So like hypotension, cardiac arrest, that type of thing. Signs and symptoms, of course, hemoptysis, you're going to be coughing up blood. And then hypoxia, your O2 levels are going to decrease. They're typically treated with supplemental O2. And then the recommendation is to place the patient on the side that's affected. So if your right lung is where your location of your bleeding is, they want the patient placed on the right side. And when I was doing the reading on it, the reasoning for this is it helps protect the other lung. So found that kind of interesting. And then the other treatments for this, you are platelet transfusions trying to help the patients clot on their own. And then there is actually something that can be given inhalation called tranexamic acid. I hope I'm saying that right. Tranexamic acid, it can be given inhalation, and it's an antifibrinolytic. So it actually helps prevent the clots from breaking down and helps the body form its own clots and helps control the bleeding. And as you can see on this imaging, like this is all blood in this individual. It's starting to pool down in that costodiaphragmatic recess. One thing I realized when I was making this presentation is it's about pulmonary emergencies, but there's so many radiology images in here. We're all going to get really good at reading chest x-rays by the end of this. And then ARDS, or acute respiratory distress syndrome, is kind of a blanket statement for a lot of things that can cause acute respiratory distress. So causes are sepsis, pneumonia, trauma, burns. You can have transfusion related lung injury, which can cause acute respiratory distress syndrome. Smoke inhalation is a common cause of respiratory ARDS. It's characterized from other respiratory things by having bilateral infiltrates. And so ARDS is always going to have bilateral opacities, and you're going to be hypoxic. And so that kind of character differentiates it from other things. So you'll have hypoxia, and then another thing that makes it emergent is that you're going to get an acidosis. It's distinguished. One other thing too that I found is sometimes when you're looking at just a chest x-ray of somebody that you think has ARDS, it might also look like pulmonary edema. And so it can be really hard to distinguish between like a heart failure patient and a patient that has ARDS. And so one thing that they use to distinguish between the two is giving a BNP on their lab work. And if the BNP is not elevated, it's not heart failure. And so then you know you're dealing with ARDS. Sometimes the opacities can get so bad that it can cause a partial collapse of the lung as well. ARDS can also lead to arrhythmias. So you'll have dyspnea, hypoxia, tachypnea, tachycardia, crackles, but it can also lead to like a ventricular arrhythmia and send you into cardiac arrest. When it's severe, you get the diaphoresis, which is just the sweating, wheezing, chest pain, confusion, cyanosis. And it's treated with supplemental O2. And if it's bad enough, they get intubation with mechanical ventilation. And then the specific treatment for ARDS depends on what's causing it. So if the patient is septic, you're going to be treating the sepsis along with managing their airway. If it's from a pneumonia, you're going to be treating the pneumonia. Whatever it is that caused the ARDS, you're also going to be treating that on top of making sure that they're still getting enough oxygen and breathing appropriately. And then we have carbon monoxide poisoning. So carbon monoxide poisoning is interesting because patients will present with 100% SpO2 when you're checking their oxygen saturations. But it leads to impaired oxygen transport. And it is the leading cause of poisoning deaths in the US. Carbon currently. So carbon monoxide has a 240 times greater affinity for the iron portion of hemoglobin than oxygen does. And so when you have carbon monoxide in your system, it actually prevents oxygen from binding to hemoglobin, and it prevents hemoglobin from delivering oxygen to the peripheral tissues. And so you get decreased amount of oxygen getting delivered to your peripheral tissues, and then once it gets to the tissues too, it can't be released from the hemoglobin itself because carbon monoxide changes the structure of the hemoglobin and prevents it from perfusing the tissues. And so then you're not getting any oxygen to your organs and peripheral tissues. So common sources of carbon monoxide poisoning are poorly functioning heating systems, improperly ventilated fuel burning. So I think the one that we all know of is the car in the garage. That can lead to carbon monoxide poisoning. Fires actually can lead to carbon monoxide poisoning. So I think it's been a common thing to occur in firefighters actually from working on fires. And then a non-carbon monoxide source of carbon monoxide poisoning is methylene chloride. And it's because it gets metabolized by the liver to carbon monoxide. And so then even without inhaling it, if you are exposed to methylene chloride, you can get that. And methylene chloride is paint thinner for anybody that didn't know, because I didn't know what that was. So carbon monoxide poisoning presents with non-specific symptoms, so malaise, nausea, headache, dizziness. And then, like I said, too, it's going to be kind of hard to distinguish because patients, when you check their SpO2, are going to have 100% SpO2. So you're kind of looking for their history to see if they've had any recent exposures to really determine if this person has carbon monoxide poisoning. Severe, though, can actually start to cause neurologic symptoms. So you can get seizure, coma, can cause heart attack and ventricular arrhythmia. And then if it's not severe, it can still cause neurologic symptoms by what's called delayed neurologic sequelae. And I didn't know this at all until doing this research, but it can end up resulting in personality changes, movement disorders, and focal neurologic deficits like vision loss, hearing loss, speech deficits. And that actually starts to occur, I think, 2 to 4 days after the initial carbon monoxide poisoning. So the half-life of carboxyhemoglobin is 250 to 320 minutes, which is a really long time. It would take the body a long time to remove that carbon monoxide from the hemoglobin. So when we're treating patients with carbon monoxide poisoning, they get placed on 100% O2. And when they get placed on 100% supplemental oxygen, that decreases that half-life from 250 to 320 minutes down to 90 minutes. So it significantly helps the body just clear the carboxyhemoglobin a lot faster. The other thing that you can use to treat carbon monoxide poisoning is a hyperbaric oxygen chamber. And so what this does is this gives patients 100% O2, but it does it at, it places them in an atmospheric environment that's above sea level. And so that increases the delivery of O2, and it decreases that half-life down from 250 to 320 minutes down to 30 minutes for the carboxyhemoglobin. So then the body's clearing it a lot faster. And then if patients are comatose, they're getting intubated. So, and then these are my references. And these are my references, and they're not done all the way, so. Does anybody have any questions?
How many places do you think have like a hyperbaric oxygen chamber? Is that like, not like, I know it's probably not like around here, but like Portland? Is that
Portland, Providence.
Yeah, they have one of them?
Mine did,
Really?
both mine actually.
Oh, the big hospital.
I would say like probably
Colorado.
major, like any major trauma center or hospital, like I would assume OHSU might have one
They
too.
didn't used to, so I don't know if they do now, but Portland, Providence is where we send them.
Yeah, wow.
But
They also used them for like necrotizing wounds.
oh, that's interesting.
I don't remember, because anaerobic infections.
Oh,
that
Like,
makes sense.
yeah, if you can put them in a chamber that is so high O2 content that you
It kills them essentially.
Mhm. Yeah, so they'd either use it for carbon monoxide or like a super severe cellulitis or abscess.
Oh, that's awesome. I did not know that.
Have you guys seen this a lot with firefighting? People that do get this at all? Are you
No.
pretty careful, right?
No, we're screwing up if this happens.
Right.
No, just suicide attempts is all I've had in with dealing with this, so.
So I think that's probably the most common thing that everybody hears of, but.
Unfortunate barbecues event, great barbecue adventures too.
And actually, yeah, we've had that where they're barbecuing in the garage.
Oh,
Yeah.
that makes sense, especially in Oregon.
That actually came up on my reading, yeah, when I was researching this, they're like charcoal barbecues, I was like, charcoal barbecues.
In poorly ventilated.
Yeah, poorly ventilated areas. Yep, which makes sense, but it just wasn't something I thought about, but yeah, living in Oregon, I'm sure people are like, oh, just put it in the garage and barbecue in the garage. I'm sure that's how a lot of fires start. Yeah, well, that's all I have, so.
That's awesome.
Good job.
Yeah, thank you.
Bailey got in just in time.
I thought I saw that, I really kind of saw like a person pop up and like,